Okay, hello everyone. My name is Jeff Donnell, and I'm President of Enterprise Health. And I'd like to welcome everybody to today's webinar focused on the legal and logistical challenges that are associated with the administration of the COVID-19 vaccine. This is the 9th in a series of webinars that we initiated last year in response to the COVID-19 pandemic. And today we have more than 365 individuals who've registered for the session. So obviously this is an important and timely topic. And we appreciate everyone, especially those of you who are braving really difficult weather conditions these days. I know here in Indiana, we have about a foot of snow on the ground. But we want to thank all of you for making time. And we also want to thank our friends at Work Health Solutions who are co-sponsoring today's event. And we're going to start off with just a couple of housekeeping items. We've muted everybody except our moderators and our panelists. We're trying to minimize background noise as much as possible. Want to let you know we are recording this session, and we will email everybody later this week with a link to access the recording. And we have a great panel with us today. It's a group of legal and occupational and employee health experts, and they include Enterprise Health clients and partners. And we've asked each of our panelists to make a few initial remarks about their observations on today's topic. And then we're going to have a Q&A session, so you can submit questions via the chat or the Q&A feature in WebEx, and we'll get to as many as we possibly can after our speakers kind of give you an overview. And our panelists today include Dean Frieders with Work Health Solutions, Amy Adelaide with Krieg DeVault, and Tim Raycobb and Amanda Guilfoyle with Phillips 66. And I'm going to start off and just give a little context on our organization as well as today's topic. And I know none of us are spending too much time in elevators these days, but this is the quick Enterprise Health elevator pitch. And we are the only cloud-based health IT solution that combines occupational health and compliance, clinical care, and employee engagement on a single, interoperable, and certified electronic health record platform. And we focus on equipping our clients and their employees for a healthier future. And we work with a mix of blue chip global corporations, government agencies, and hospitals and health systems who operate their own on-site employee health clinics and also provide employee health services to other organizations. Now, I was recently watching the BBC World News, and I was reminded that in the United Kingdom, they refer to a vaccination not as a shot, but as a jab. And as I watched the story on the measures that Great Britain has put in place to jab its citizens, it brought back memories of attending boxing matches as a kid with my father. And you'd hear the corner man barking out instructions to the fighter to jab, jab, jab. And of course, the opposing fighter is doing their best to avoid the punches. And today we find ourselves engaged in really an epic and global fight against COVID-19. And one of our best weapons is administering a flurry of multiple jabs in the shortest time possible to put our opponent, which in this case is a virus and its rapidly multiplying variants, on the ropes and ideally out cold on the floor of the ring. But this coronavirus has proved to be pretty wily, a skilled fighter, if you will. And despite all of our training, we haven't really encountered an opponent quite like this in the opposite corner in roughly a century. And getting all those jabs in has proved to be a rather daunting task, and we're wrestling with some heavyweight issues, including things like the fact the actual timing of vaccine rollout was a bit of a mystery. And many were caught by surprise when vaccines all of a sudden became available in mid-December, and that triggered a mad scramble among states, hospitals and health systems and others who were involved in coordinating the first round of vaccines. Here in the US, vaccination logistics were left largely to states, and every state is doing things a bit differently in terms of risk stratification for groups for allocating vaccines. And in addition, every state has some kind of a vaccine registry, and in some states, there are even county and city registries. Add in the change of administration at the presidential level, and the complexity and rate of change and refinement has been nothing short of dizzying. And of course, there's not just one approved vaccine, but several, with different transportation and storage requirements. And the initially approved vaccines require 2 doses, with the second doses administered at different intervals. And then we have new vaccines coming online soon to add to the complexity. And we also have people advocating giving out the first dose of a double dose to more people and delaying the second dose just so we get more people to have that first round. Again, it adds up to more complexity, and this is a moving, bobbing, and weaving target. And I know as we gear up to expand vaccination sites and work through some of the early bugs, we're starting to run into supply issues. Many cities and localities are turning arenas and stadiums and pharmacies into mass vaccination sites, but they don't yet have mass vaccination supplies. And across the pond, we're seeing Europe and the UK engage in some post-Brexit bickering over vaccine availability. And there are many third world countries where they have yet to administer their very first vaccine. And then just to make things more challenging, there's a full spectrum of attitudes and behaviors associated with vaccination. And that ranges from those who are so eager to get jabbed, they're trying to cut the line, to those who are dead set against getting the vaccine for a whole host of reasons. And I know at Enterprise Health, we've been working with our clients to help them manage their COVID vaccination efforts. And we were fortunate in that we did not have to start from scratch on this effort. We were able to modify some existing mass immunization functionality that's traditionally used for things like annual employee flu programs. However, it was not quite as simple as just adding another vaccine to that module and calling it a day, given all the aforementioned complexity. And we were very lucky in that one of our health system clients, Northwell Health in New York, really anticipated that the vaccine would be available in December. And so we started working with them well in advance to prepare. And they actually administered the very first vaccine given in the US to one of their nurses on the morning of December 14th. But certainly over the last 60 days or so, it has been nothing short of a mad scramble as we worked first with our health system clients to get their employees vaccinated. And now a lot of our corporate clients are gearing up for their vaccination programs. And we've been able to amass quite a bit of experience in a short time. We've been refining functionality on an almost daily basis based on feedback from administration sites. We've quickly set up dozens of new interfaces with different registries. We've created a lot of new reports to track progress. And really, as with all things COVID over the last year, our clients, and really by extension our organization, has had to operate on an unbelievably agile footing. And then just to make things more interesting, several of our clients have recently asked to use our solution, not just to manage vaccinations for employees, which is really what our solution is built to do, but also to use it for vaccinating the wider community, things like first responders, essential workers, spouses, family members, really anybody approved to get a vaccine. And, you know, we're as eager as anybody to speed up the pace of vaccination and get back to some kind of a semblance of business as usual. So we are happy to help our clients as they jab, jab, jab. And of course, our clients, like everybody I'm sure attending this webinar, everybody's dealing with all kinds of legal and logistical challenges. Can you require employees to get vaccinated? What kind of proof of vaccination is required? How should you document declinations? How do you set up a mass vaccination program? What precautions do you need to put in place when vaccinating given COVID? What role should technology play? How do you educate employees and community members on vaccine benefits and overcome some of those fears and concerns? So fortunately, we have a great panel who's going to enlighten us on some of these topics today. And our first panelist is Amy Adelaide. And Amy is a partner and chair of the labor and employment practice at Krieg DeVault, and it's a law firm that we work with, and they specialize in occupational and employee health. And Amy has been very active in helping a wide array of employer clients address COVID-related legal, regulatory, and compliance issues. And she's going to talk about some of the applicable regulatory standards and their impact on employers and employees. Amy, let me pull your slides up here. All right, turn it over to you, Amy.
Perfect. Thank you, Jeff, and thank you, Enterprise Health, for inviting me to be part of today's webinar. You know, it's very interesting as we have moved through the various stages of the COVID-19 pandemic, and our focus has shifted for necessary and obvious reasons as we've moved through the pandemic, from focusing on excluding or removing our employees from the workplace to considerations regarding returning our employees to the workplace, antibody testing, COVID-19 testing, all of those issues relating to employees. And now moving to what I think is the most exciting phase of all of those phases, which is vaccinations. And, the legal issues associated with and that employers are having to consider concerning COVID-19 vaccinations and the policies that you want to put in place for your employees. Quick disclaimer here that the information I'm providing today is just that. It's general information and shouldn't be construed as legal advice. Many of these issues that I'm going to be walking through here quickly in the next 15 minutes are things that your organizations hopefully are consulting with your legal team on, and if not, should be, because there are some pretty complicated considerations to walk through as it relates to the legal issues associated with COVID-19 vaccinations and your employees. Next slide, please. All right, COVID-19 vaccinations in the workplace. Really two big questions here for employers, which are can we and should we? In some ways, one is a legal question and the other is more of a business question. And in some ways, the legal question may be easier than the business question. And as you'll see this morning or this afternoon, depending on where you are, our panelists today are going to bring different perspectives as to those two very different questions, which perhaps have very different answers. So just running through, some of the questions that we should be asking as employers, as organizations considering COVID-19 vaccinations. Who are we having perform the vaccinations? Is it us, the employer? Is it a third party we're contracting with, or a completely unrelated third party, such as the state or a county? Who would we require to become vaccinated out of our workforce? Are we going to require it for every employee or only certain positions? Next, what action can and will we take if an employee refuses to be vaccinated? If we're going to put in place a mandatory vaccination policy, are we really committing to making the decision to terminate employees who refuse to become vaccinated? Next, how will our approach be different now and later? As I've advised employers throughout COVID, this is an ever-changing set of circumstances, and employers must be nimble with respect to their policies as it relates to COVID. So while an organization may decide, presently we're not going to require vaccinations, it could be that at some point down the road, your organization is going to change that approach. Next, what are the legal risks to mandating and encouraging employees to become vaccinated? We'll talk through some of those in a few minutes. What safety precautions will remain for our organization post-vaccination, including if we have employees who refuse to be vaccinated, are we going to allow them back into the workplace? And what will the rules be that are in place for those employees and others? Will we offer incentives, and what are the legal limits that might come into play on offering those incentives? And then finally, I've been getting the question, should we get waivers signed by employees? I get that question both in the context of waiving any harm they may receive or adverse reaction to becoming vaccinated, and also employees who refuse to be vaccinated and then go back into the workplace. Next slide, please. Okay, so let's spend some time talking about this first question of can we require vaccinations? Generally, as most people have probably read or heard by now, generally the answer is yes, with some caveats. There are two main legal objections that an employee will likely raise to a mandatory vaccination policy, or even in one that's strongly encouraged. And those are based on religion under Title VII of the Civil Rights Act and disability under the Americans with Disabilities Act. In addition, public employers, state, county, city, public employers have added considerations under the U.S. Constitution when it comes to requiring vaccinations that they also must walk through and consider whether a mandatory vaccination policy is permissible. Next slide. Let's talk about the religious accommodation considerations. So as I said, one of the reasons an employee may refuse to become vaccinated is for religious reasons. Title VII of the Civil Rights Act says employers can't discriminate against employees based on religion, and as a result, requires that employers must accommodate the sincerely held religious beliefs of their employees. So an employee may say, I'm refusing to receive the COVID-19 vaccine due to my sincerely held religious beliefs, at which point the employer and the employee must consider, okay, what reasonable accommodation might be available to accommodate this employee? The limitation under Title VII for religious discrimination is, would that reasonable accommodation create an undue hardship, which for purposes of religious discrimination is defined as more than a de minimis cost or burden on the employer. It's actually a pretty easy standard for an employer to meet when we're talking about religious accommodations and accommodations for COVID-19 vaccinations. Documentation, what accommodation is needed and why? That's the information an employer wants to get documented from its employee. Another question on this that I commonly get, though, is what if the employer has bona fide doubts about whether that employee truly holds, sincerely holds those religious beliefs? The EEOC has said, basically, you should assume that they are sincerely held. However, there are circumstances where you may have good reason to question and require further information from an employee. I would encourage you that if you have a situation like that where you are questioning an employee's sincerely held religious beliefs, reach out to legal counsel and walk through that analysis and whether you should be requesting additional information from that employee or not. Next slide, please. So in addition to religious accommodation considerations, we have disability accommodation considerations. So this is where an employee is refusing to be vaccinated for a medical reason, right, due to an underlying disability. And what employers want to request here is documentation from a healthcare provider indicating that that employee should be excused from the vaccination requirement because of a medical necessity. Again, like with the religious accommodations, that employer needs to engage in the interactive process to try to find a potential reasonable accommodation. Along these lines, the EEOC has said to employers, look to CDC and OSHA guidance for ideas about ways to accommodate that employee. Maybe it's working from home. Maybe it's allowing that employee to work in an area where they won't be around other employees. So employers have to consider, is there an effective accommodation available to this employee that wouldn't create an undue hardship on the employer? The next critical question really is, let's say that there is no reasonable accommodation that really would permit a safe situation. But the final question the employer needs to ask there is there any way to avoid that employee posing a direct threat to the health or safety of others or themselves if they were to return to the workplace? As we know, the EEOC has already said that COVID-19 presents a direct threat. So this may give employers an argument if they really want to push it that, there is no reasonable accommodation due to the direct threat involved and based on that employee's specific job. Next slide, please. Other legal considerations of mandatory policies, I would say if you have a union in your workplace, you're going to want to check that collective bargaining agreement to see what the implications would be of a mandatory vaccination policy. As I said earlier, public employers face additional challenges under the US Constitution to mandatory vaccination policies. There are also risks associated if, for say, let's say an employee has an adverse reaction to a vaccination. Will they then sue the employer for making the vaccination mandatory? My quick response on that would be that that claim would likely be a workers' compensation claim. And in fact, some states are revising their workers' compensation statutes to provide immunity for employers in those situations. And also consider whether you have state legislation that prohibits a mandate. There is such a bill being proposed in Indiana that would prohibit employers from requiring a COVID-19 vaccination, or really any vaccination, really if the employee just decides they don't want to get it. So be sure to check state legislation in all areas where you have employees on this issue of mandatory vaccinations. Next slide, please. Employers also have additional legal considerations under the ADA and GINA. So if an employer mandates and provides the vaccination, meaning the employer is going to administer it or contract with a third party to administer it, that employer is, through the screening questions that would be asked prior to the vaccine being administered, that employer is making medical inquiries. And under the ADA, there are limits when an employer can make medical inquiries of its employees. They must be job-related and consistent with business necessity. So if an employer is going to administer the vaccine or contract with a third party to administer the vaccine and collect this information, that employer is going to have to be able to meet that direct threat standard that I mentioned earlier. You would have to be able to establish that that employee would pose a direct threat to the health or safety of themselves or others if they were not to become vaccinated. So just additional considerations to keep in mind there if you, the employer, are administering the vaccine or contracting with a third party. Next screen, please. Next question, do we want to require COVID-19 vaccinations? I know others on the panel will be digging a little deeper into this issue, but things that I'm reading about and hearing about from my clients include employee morale. Will our employees feel like we're infringing upon their personal liberties if we mandate vaccinations? Also, staffing shortages. Are we going to lose employees to the point that there's going to be a disruption to our organization's operations because we're mandating vaccinations? Also, the effectiveness of a mandate, given the religious exemption issue and the disability exemption issue I mentioned earlier. We all know that some remain uncomfortable, opposed. Some are already anxious. Most are already anxious as a result of the COVID-19 pandemic. And by mandating vaccinations, are we increasing that anxiety? Next, what are most employers doing? I would say that most are not currently mandating, but as I said, most things related to COVID-19 or all things related to COVID-19 are subject to change. Most are currently encouraging, but are not currently mandating. Next slide, please. Ways to encourage vaccinations, which I know we'll hear about from others, including Dean, but thinking about leadership setting an example or providing stories about vaccinations, their own personal story. Next, access, so informing your employees how they can sign up to become vaccinated. Educating employees through information, through credible information about the vaccines available. Not information they might be getting through social media and other resources that may not be credible. And then finally, the issue of offering incentives. Jeff, if you can move to the next slide, we'll dig in a little bit deeper on incentives. Possible incentives for employees could be, offering time off, paid time off to become vaccinated. Some employers are paying bonuses and providing gift cards to employees who agree to become vaccinated. And move to the next slide. There are some legal issues, however, that employers need to consider if they are offering vaccine incentives. Again, it depends on whether that vaccine is being administered by the employer or that employer's third party who they've contracted with. If so, there are some ADA considerations that may limit the incentive that can be offered to that employee. However, if the vaccine is being administered by a non-contracted third party, then there are not these limits on the incentives that would be imposed by the ADA. Next slide, please. Finally, requiring waivers from employees who refuse the vaccine. There are certainly questions as to the enforceability of those waivers, whether under public policy arguments. As I said, if an employee were to have such a claim, it would probably be a workers' compensation claim, and that might be the employee's sole remedy. And the other thing about requiring waivers is that employers cannot waive their legal obligation to provide a safe workplace under OSHA. And so really employers have to think about this issue from two perspectives. One, can you create a safe workplace without mandatory vaccinations, and how will you do so? And also, what are you going to do to create a safe workplace without mandatory vaccinations? So, thinking from both perspectives of, if we don't require it, or if we do, how are we going to create that safe workplace for our employees, which is our continuing obligation? And what are our policies going to be regarding social distancing, masks, et cetera, remote work going forward, despite the availability of the vaccines? And I believe that is my final slide for now. So I will turn things back over to Jeff.
Okay, great. Thanks, Amy. Next up is Dean Frieders, and Dean is General Counsel with Work Health Solutions, and they're a rapidly growing organization that offers employers a choice of mobile, near-site, or on-site employee health services. And they've actually been using our technology to provide COVID-related services to a wide range of corporate, health system, and state government clients. And Dean is going to talk a little bit about the practical workplace rollout of a COVID vaccination program, including bargaining unit discussions and implications for worksite medical programs. So take it away, Dean.
Great. So as Jeff indicated, Work Health Solutions, we provide occupational health services in all formats. We have some sites where we have personnel on site working within a production, manufacturing, distribution facility, office facility, offering a full range of occupational health solutions. We have some locations where we are near site, where we'll have a physical clinic located near a client location, and they send their personnel to our office to receive treatment. And then some locations where we do mobile services, where we will deploy a team out to a site to do OSHA screenings or other occupational health related services for short-term deployments. So let's jump in the Wayback Machine here. Where were you when you first talked about COVID in the workplace, or you first realized how bad it was going to get? One of the unique things about Work Health Solutions is that all of our personnel came from the private sector. We all came from your position as clients. So back in January, February 2020, I was a city manager in Illinois. I remember hearing about COVID on the news, and we had a staff meeting, our weekly staff meeting, and we sat down and talked about it. We thought we were way ahead of the curve. We ordered some rubber gloves and some Lysol and thought we were ready for anything. By March 20th, I remember sitting at my desk and turning on the news and hearing Governor Cuomo shut down the state of New York. And my wife asked me to pick up some groceries on the way home, and I went to Target and the shelves were bare. And that was the first time I had some idea of how bad things were going to go, although I had not a fully conceived idea. I don't think any of us could have imagined. Looking at that timeline, January 7th, COVID was identified as a new novel virus. First case reported in the US March 1st. It was declared a global pandemic 10 days later. We started seeing states shut down within a few days after that. Moving forward to today, nearly 500,000 deaths, nearly 30 million cases. So looking back, let's say that you could send yourself a tweet back to February 1st, 2020 yourself, and what would you tell yourself in 280 characters? What would you say if you could give yourself a warning about what was to come? What supplies would you tell yourself to order? What prep would you do? What business strategies would you implement? Perhaps most tellingly, I think in retrospect, many of us would have started toilet paper distribution companies and we would have retired wealthy by now. So what would you name your toilet paper distribution company? I'm going to tell you what I would tweet myself if I could go back in time in just a couple minutes here. What has the impact of COVID been on our business? We can roll right forward here. The impact of society, again, 30 million cases, close to 500,000 deaths, massive lost productivity. This has been an international incident, worldwide obviously, but when we look at our country, every state has had shutdowns of some sort, most of them implemented over a roughly 45-day window, March, April of 2020. And ongoing to today. What are the long-term impacts on business? What will those impacts be? Are we going to go back to having in-person meetings? Are we going to be wearing masks forever? What are we doing for sanitization? What are we doing for occupational health? What are or what should the occupational health impacts be? The Society for Human Resource Management estimated COVID-related costs to U.S. domestic businesses at roughly $1.3 trillion. That estimate was from April of 2020, roughly 2 months into the pandemic. Those costs are lost time, lost productivity, sick leave, medical costs, lost opportunity. You're going to notice I jumped over health insurance, unemployment, and workers' comp because those are costs that we're not going to know for years. The long-term implications of the pandemic are things we're not going to understand for years to come. So can we make vaccination mandatory? Amy talked very eloquently about that. Yes, we probably can. Should we make it mandatory? Well, we need to look at the site, at the industry, at personnel-specific considerations. We're going to talk about why more employers should consider mandating or having a highly effective volunteer vaccination process, and also look at the impact on businesses. Are COVID vaccines safe? We have done tens of thousands of vaccinations. We've been doing vaccinations since mid-December. There's an incredibly low risk of serious complications. There's a minor risk of discomfort with the second injection typically, but minor body ache, muscular pain type things. Are they effective? Moderna and Pfizer, both around 94-95% effective. You may have been hearing in the news lately about the new single-dose Johnson & Johnson vaccine. That's about 66 to 72% effective, depending on which study you're looking at. And we're hoping to see more data on the efficacy of that in the days to come. The Johnson & Johnson vaccine can be stored at regular refrigerator temperatures as compared to Pfizer, which has to be stored at about negative 80 degrees Celsius, and Moderna, which has to be stored at about negative 20 degrees Celsius. So are they safe? Yes, by and large, they are safe. Are they effective? They're showing pretty good effectiveness when you look at how serious this illness is. But realistically, isn't COVID almost over? Hasn't the curve flattened? Why are we caring about vaccines now? Isn't this something from 2020? Well, there are new strains of COVID being discovered every week. There are some experts that are saying this is COVID-19, get ready for COVID-21, COVID-24, other strains coming down the pipeline. Moreover, vaccines are not 100% effective. And for herd immunity to work, we need to have about a 95% public vaccination rate. Herd immunity is the concept that enough people have been vaccinated that even if one person gets ill who hasn't been vaccinated, they won't be able to spread the disease. We have to get to 95% public vaccination before that will truly be effective. The secondary and tertiary complications from COVID are severe. Some people have COVID and are asymptomatic and don't realize they have it. And some people are developing lifelong complications or fatal complications that we don't have an advanced understanding of. The other reason that we need to think about COVID treatment is because of money. Frankly, we're businesses, and the impact that COVID is having on our productivity and our workforce is dire. So how do we prevent outbreaks? We wear masks, we sanitize, we social distance. Candidly, vaccination is the most effective way of preventing outbreaks, of reducing absences, reducing employee downtime, increasing productivity. This is the time to focus on occupational health. If I was sending myself a tweet back to February of 2020 when I was working as a manager of a large and productive organization, I wouldn't have said order masks. I wouldn't have said order more Lysol. I would have said look at your occupational health programs. Why is that so critical now? Well, one of the reasons is because we need to address the latent high-risk health issues that our employees have. Obesity, heart disease, diabetes, these are all things that put you at a far greater risk for COVID-related complications and the secondary and tertiary complications that we just talked about. Moreover, they're the same things that put your employees at a higher risk of every other type of health issue. They're comorbidities for many other types of disease, and if you can address them and have a healthier workforce, you can be more resilient and more profitable. This is the time to communicate the importance of health issues in the workplace. Employees are listening. If you can enhance your employee health, you can enhance their productivity and their happiness, and that will simply make you more money. We have OCC health programs that have demonstrated a 260% return on investment just based on avoiding preventable illness and injury. There's never a bad time to look at occupational health. This just happens to be a really fantastic time to look at it. So what does that practical workforce rollout look like? We'll jump right into the next slide here. It is critical that before you go to your employees and say, we're going to have vaccinations, whether mandatory or voluntary, you have to get them to think about it. You have to educate, share factual information on vaccination efficacy and availability. You have to use objective, recognizable third-party sources of credible information. Centers for Disease Control, FDA. You have to build consensus and understanding with employees before you start talking about any on-site programs. Move to engagement. Ask what their questions are. Find out what the answers are and provide responses. Follow up. Communicate with your employees via posters, via email, pamphlets for distribution. Whatever communication venues your employees are using, you need to use those as well. Hold webinars like this with your employees and engage. Leverage trusted medical or clinical partners to engage with your employees. At locations that we're providing on-site services, we are a core part of the employer outreach, reaching out to employees, providing factual information, and building understanding and consensus upon which a reasonable and well-founded program can be started. So jumping back to July of 2020, we were asked to conduct on-site COVID testing in a prison facility with 5 bargaining units. The facility management said we needed to start testing on Tuesday. We talked about doing some employee outreach and engagement, and they said, no, we just have to launch testing as quickly as possible. We showed up on Tuesday. The immediate response of employees was grievances. Grievance from every bargaining unit, consternation, anger, shouting, led to a lot of meetings, a lot of engagement, a lot of information, a lot of sharing of data. It led to a lot of employee and bargaining unit consternation. And we had to overcome a lot of obstacles before we got to a point where employees could even begin to support the program. And that was just COVID testing, not vaccination. So we go through our education engagement process. What's next? We have a clearly defined written policy on vaccination and parameters. Who is it available for? If possible, everyone. You may have to phase in your vaccination depending on the types of workers that you employ. Who is or can be exempt from the program? Amy talked about that in detail. When and where is it offered and who pays? Our recommendation, eliminate as many barriers as possible. Offer vaccination on site during work paid by the employer. We have some innovative programs where we're partnering with public health authorities and offering on-site vaccination using a public health supply. It's the best way to ensure a healthy workforce. So what are the implications for occupational health programs overall? How do we plan for COVID-21? The next pandemic is coming. There was SARS in 2002, H1N1 in 2009, MERS in 2012, Ebola in 2014, Zika in 2015, dengue fever in 2016, and COVID in 2020. If you're an international company, you are affected by each one of those pandemics in some fashion. If you're a domestic company, COVID may be your first experience with them. But let's talk about what the Wall Street Journal has said on the pandemic. The rapid and global spread of the deadly new coronavirus caught households, business leaders, investors, and policymakers off guard. But health experts and economists who study pandemics say it should not have come as a surprise at all. Epidemics of infectious disease have become a regular part of the global landscape in the past quarter century, thanks in part to economic trends including urbanization, globalization, and increased human consumption of animal proteins as society becomes more prosperous, these experts say. The public needs to prepare for more pandemics, they add. There will be more pandemics to come. Having a more resilient, healthier workforce is a workforce that is more resistant to the next pandemic. and more resistant to the secondary and tertiary complications that come with it. Having an infectious disease plan in place is critical. Having a health provider on-site, near-site, or mobile that can help you respond quickly to all sorts of occupational health concerns is critical. These produce happier and healthier employees. These produce a healthier bottom line for your company. So what are you doing to prepare? What would my tweet tell me to do? Back in February of 2020, I'd be looking at what we call our IIPP, my bloodborne pathogen program, my vaccinations, my airborne infectious disease plan, my cleaning and sanitization plans. I'd go back and look at our OC health, wellness, and surveillance programs. Are we doing biometric evaluations? Are we doing blood tests and physical assessments? Are we implementing steps to support our employees who have latent health issues that we can work on? I would look at our electronic health record. So all of the data in the world on your employees' health is no good if you can't capture it and monitor it. The use of something like Enterprise Health that allows you to capture that data securely, restrict access to it to personnel who have a business need to know, and engage in trend monitoring so you can identify potential occupational health issues before they become your workplace pandemic. These are critical steps. They also allow you to evaluate your key performance indicators and return on investment for your OC health program. What does occupational health mean to you? Is the pre-employment screening just a prerequisite? Are you just checking a box? Yep, that was done. Or are you really looking at your employees to determine their risk for injury or illness and implementing a responsive program to enhance their health? That's where businesses need to be going. So what should every employer do right now? You should be evaluating the potential for an on-site vaccination program if you want to have a progressive response to the workforce, to the occupational health considerations that still exist with COVID-19 in the first quarter of 2021 and will exist for the months to come. You should also evaluate your overall occupational health programs, on-site, near-site, or mobile services as they may be best configured for your unique needs. And you should evaluate the potential for changes in the intensity of the service that you're currently offering. As you make those changes, consider your messaging, consider your tone, consider the employee outreach and education that you engage in. We're working with an employer right now who started their campaign on occupational health with a message that says, because we care about you, we are investing in your health and wellness. It's a great message, and it's one that we love to share. So the role of your OC health provider is not to just check a box. Yep, we did the pre-employment screening and they can lift 50 pounds. The role is to enhance your employee health, reduce the frequency and severity of injuries, reduce and mitigate the effects of injuries, and make your workforce more productive and profitable. Through a comprehensive OC health approach, you can be better prepared for COVID, for the next pandemic, or for any challenges your business faces with happier and healthier employees. This is an opportunity to rethink your approach to occupational health and the way that you think about the well-being of each and every one of your employees. This is your opportunity to reset and be prepared so that when the next COVID rolls around, you have the toolbox you need to be able to respond immediately. And thank you so much, Jeff, for the opportunity to speak today.
Thank you, Dean. Great job. Okay. Well, now that we've heard a little bit about the legal issues, and I think Dean did a great job of sort of, talking about, the importance of having a good occupational and employee health program. And now we're going to hear from an employer who's dealing more with some of the logistical challenges of setting up a worksite COVID vaccination program. And we're actually joined today by two panelists from Phillips 66. So we have Tim Raycobb, who's the Director of Medical Compliance and Policy, and Amanda Guilfoyle, who's an analyst in the HR and Business Solutions Group. And Tim and Amanda have been preparing for the administration of COVID vaccines for not only Phillips 66 employees, but also their family members. So Tim and Amanda, please take it away.
Good morning. Thank you, Jeff. My name's Tim Raycobb. I'm a physician assistant with Phillips 66, and I'd like to give a little background on where Phillips started back on January 20th of 2020. This was over a year ago. Phillips realized that there was a highly infectious virus going through Wuhan, China. And our health services and crisis management group got together and started developing a contingency plan for what would happen if this ever came to the U.S., which unfortunately occurred in February of 2020. In early March of 2020, we updated our emergency response plans to include we modified our pandemic flu plan to a pandemic coronavirus plan. And we started doing COVID antibody testing in April of 2020 to ensure that our employees were safe, and we try to mitigate transmission of COVID throughout our workplace. So in October of 2020, our group determined that there was going to be a high probability that corporations would likely be asked to participate in vaccination programs for COVID-19. So we started developing a plan to partner with the different state health agencies to determine what sites would be eligible for enrollment, and started determining what resources would be needed and what logistical challenges that we would face as we anticipate on becoming vaccination sites. So I'm going to give more of the micro picture of what we've developed in Bartlesville, Oklahoma, which is where Amanda and I are based out of. And I think Amanda's going to give more of the macro picture of where we are corporate-wide in our response planning. So one of the things that we have to determine is, where are we going to locate our vaccination site? So our Bartlesville campus, we actually have two different campuses in Bartlesville. One's a research center, one's a corporate headquarters site. We have approximately 1,600 people in Bartlesville, but we also support a joint venture in Bartlesville called Chevron Phillips Chemicals, which has an additional 300 people. So we support about 1,900 people in the Bartlesville area. So we looked at our two large buildings, and we realized that those would be unsuitable because they have restricted access. And with COVID being transmitted, we locked down access to those two sites to prevent anyone other than Phillips employees and contractors from accessing our buildings. So we realized we needed an external facility that would be easily accessible to employees, contractors, and our company determined that we would extend our vaccination program to eligible household members. So as we looked at our spaces, we realized we had a very large print center that had been decommissioned approximately 3 years ago, that had 50,000 feet of usable space. The access to the building could be programmed to allow anybody into that building. So we took a look at it and determined that it would meet our, it would be suitable for our needs. So as we looked at the building, we realized there'd be three main areas that we had to develop resources for. We had an intake area where people would have to register and be enrolled into Enterprise Health. We'd have to have a vaccination station that would be manned by people who were certified to give vaccines, and then we had to have a monitoring area so that we could monitor the individuals for 15 or 30 minutes, depending on their health status. And if anyone did have a adverse reaction, we also had to have a separate treatment area so that we could isolate those individuals and not have them treated in a large monitoring area filled with other people. So what we determined was that we'd have to have an area where we could have a high flow of individuals. We estimated that once we geared up, we would have to be able to process approximately 400 people a day for our corporate facility. And we would need, on average, approximately 20 people per vaccination clinic in order to operate at the efficiency that we wanted. So as we looked at our workflow, we realized we needed 3 intake stations that people would have access to computers to enroll people into enterprise. And then we would need a minimum of 3 vaccination stations. Each station would be manned by a vaccinator and a medical scribe to complete the immunization card. We'd have 2 people who were designated as rovers to circulate around, provide supplies, obtain or get vaccine out of storage, draw up vaccine, assist as needed, and then 5 individuals in the monitoring area, 2 for check-in and monitoring time, and 3 to monitor the individuals in the holding area and provide emergency response. And then we also had 1 individual at the prior to intake who was doing temperature monitoring on every individual coming into the building. And then we had 2 security individuals to maintain efficient traffic and patient flow. So then we have to consider what was going to be vaccine availability for us. And obviously that's entirely dependent on the Oklahoma State Health Department, how much they receive from the manufacturers and federal governments. We also understood that we'd be restricted to vaccinations in alignment with the state regarding what the current tier status was. And because we are dependent on the state, it's kind of a stop and go process. We receive vaccine, we administer it, and then we have a waiting period as we await more vaccine or the state moves on to the next tier. And unfortunately in Oklahoma, we really cannot request vaccine until our current supply has been expended. So there's always a time lapse between expending that vaccine and obtaining new vaccine. Next slide. And then one of the things we had to overcome was population resistance to the vaccine. So Amanda, I think will probably address this.
Hey, Tim, I think we've lost your audio. Hey, Amanda, are you out there?
I am. We just received a message from Tim that he lost internet connection.
Okay. Well, maybe you can pinch hit here and finish his part out and then do yours.
Sure. So for population resistance, like he said, we got about a 79% survey response rate. That has gone up in the last couple of weeks with some of our initiatives around teaching moments specific to the vaccine. And then 78% requested a vaccine for themselves and their household members. So of those that are responding, we do have a pretty good response rate of those opting in. Phillips 66 approach was that this is an opt-in approach, and if you opted out in the initial wave of offerings, then you could opt in at a later time. So 21% of our overall population group did not respond, or they declined the opportunity to receive the vaccine completely at this time. So reasons for declining the vaccine, it came from a variety of reasons. Generally, I just don't take vaccines of any type. So, those that are most resistant to vaccinations, such as your annual flu vaccine and that type of thing. I think that resistance was pre-expected. And then the vaccine is just too new. We don't know what the long-term risks are for those vaccines. So we've heard a lot of that. There's some conspiracy theorists out there. So we've heard some of that, not too much from our Phillips 66 employees, but that is out there. And then the state response issues. Tim, are you back?
Yeah, I'm back.
Okay. I just jumped in. We're at state response issues.
Got kicked off for some reason. So a lot of people are concerned about the state response. We've had some issues where people in our area have been scheduled and then vaccines not available. They've had their appointments canceled, been rescheduled, been canceled. And so when we reach out to people who have had multiple episodes of inconsistency with the state, they're a little disinclined to participate in our program. And then there's also some questions about if they need evidence that they've been vaccinated and they've lost their vaccination card, how are they going to obtain information from the state? So part of the issues is that there's lagging communications with the state health department, IT, and the availability of obtaining vaccination reports. And then the last reason is people are just, because of the new vaccine, they're just waiting and observing to see what happens with the vaccine. They're not dead set against getting the vaccine, but they are more comfortable just waiting and observing other people's reactions and responses and waiting to see if there's going to be development of a general herd immunity, and they may not have to get vaccine then. And then there's the storage and handling logistics issues. You know, Dean brought up earlier that each vaccine has different storage requirements. So it's kind of ironic that the state doesn't seem to have a real good idea of what the handling capabilities of our sites in Oklahoma have. For example, here in Bartlesville, we do have the capability for ultra cold storage along with standard storage. So they sent us the Moderna vaccine. We have another site in Ponca City, which is about 70 miles from us. That's a refinery. They do not have ultra cold storage capability, but they were sent the Pfizer vaccine for some reason. So they had to basically use vaccine immediately upon receipt because they didn't have storage capability. Whereas if we had received Pfizer, we could have kept it in a frozen state until we did need it. And the other thing is that because we were having to shuttle back and forth from our main clinic to a satellite building, we had to develop storage capability in the satellite building to store vaccine on the days we had vaccination clinic. And then the last issue we had to address was we did not get adequate supplies from the state or Moderna as we were promised. We were told that for every 100 vaccines, we would receive 10% more supplies than vaccine. That did not actually occur, so we ended up having to procure certain supplies on our own. And then the final thing was after we overcame and developed plans for the previous issues, we had to determine how were we going to utilize Enterprise since it is our EMR. So we had to work closely with MIE and Enterprise regarding communications, scheduling, because virtually every state requires immunization information system data input on a 24-hour notice. With the current system, we're currently doing a dual point data input where we have to enter everything into Enterprise and then turn around and enter everything into the state IIS. So we are working on developing interfaces for each state IIS. However, each state has a different IIS standard. For example, Oklahoma uses HL7 real-time file transfer, whereas Texas uses FTP protocols, which are unidirectional, don't give us a very good error feedback if there's any data that's missing. And then, as Jeff brought up, we have to work with MIE and Enterprise on adapting some of the reports that are available in Enterprise and modifying them for COVID-19 metrics and reporting. So that's what I have on the logistics, and then Amanda will take up her portion, I believe, regarding how we integrated Enterprise system.
Yeah, thanks, Tim. So I am a business analyst, an IT analyst, and I've worked very closely with health services over the last 6 years. We integrated with Enterprise Health a little over a year ago. I guess it'll be 2 years in July. And I first want to start by thanking Jeff and Emily. Your teams are amazing. I haven't worked with anyone in enterprise health that just doesn't really amaze me. So really great response rates, really great brainstorming. How can we make this happen, folks? And love to be part of that team as we roll this out. The first thing that we felt we needed to do is develop an opt-in survey, and we felt like we needed to do this as an approach to not only understand what employees, household members, and contractors may be interested in receiving the COVID-19 vaccine, but also collect enough data so that we're able to prioritize the rollout of that vaccine, because we noticed very early on CDC had some guidelines on how the vaccine was going to be distributed, and states were following suit. And I'm glad we took that approach pretty early on, because that has indeed been one of the biggest challenges that we have, is at some points we have vaccine on hand, but we don't have a large population that fit the category of the rollout prioritization or the stages that the state is requiring us to adhere to. So in that opt-in survey, we did roll it out to employees and what we call internal contractors. So those contractors that have an actual contractor portal that we service, and they can log in just like an employee can. In that survey, we collected age, health conditions, and high-risk employment information on primarily those household members. So when an employee opted in, they also have the option to list their household members, their names, their ages, and then we listed the CDC health conditions that make you high risk for COVID complications, and also the list of employment categories that would put you in a higher prioritization for receiving the vaccine. So we also use the enterprise health portals to provide our documentation. So the emergency use authorization documents. Our legal department also creates some internal data privacy statements that they wanted us to provide to all those that would be immunized. And then we also solicit the completion of our consent form for the COVID-19 vaccine on our portal systems. And then we're also, previously, we did not have the schedule capability on our portals for employee self-service or contractor self-service, but we did opt in for that so that employees can schedule or change their vaccine appointments as needed, just because of the high volume. I know a lot of folks are already using that for flu vaccines, so we followed suit in that for the COVID vaccine. And then for employees and internal contractors, like I said, they have that self-service schedule opportunity. But for household members and external contractors, we opted in for a portal system that would create a temporary chart, essentially in enterprise health, so they can log in. They can see all of those required documents that we provided to the internal contractors and employees, and then they can also complete their consent form. So everything stays electronic. We're not doing anything on paper. So this is just an overview of what the process workflow looks like. So we run the opt-in survey report within Enterprise Health that gives us feedback on who completed the survey, who their household members are, and again, those priority groups that help us determine who's going to get the vaccine first. And then we receive information from Tim from the health department via Tim on how much vaccine we're going to have available and when we expect it to come in. And then we start setting up our appointments. We make sure that we have the staff availability. Like you said, it takes about 20 people to run the process. And then we start booking those appointments. We then use that same opt-in survey report in an Excel format, and we put that into our import template, and we enroll those employees via an import that are on our priority listing for the upcoming vaccine clinic. When that occurs, we already have it in place where the employee and the contractor will receive a notification they've been enrolled in a program. They have items out on their portal to complete, and they can schedule their appointments there. The first few rounds, we've done just over 500 doses in Bartlesville, like Tim was describing earlier. Of those, we did do a lot of scheduling those folks and just giving them a date and a time to show up rather than giving them a choice in when they're scheduled, just so that we had a little more control over the first few clinics. The check-in process is probably the most time-consuming piece. So as they approach the doors, their temperature is taken and they are directed to a check-in person. We have 3 to 4 check-in people, depending on how many we're doing that day. That check-in person is taking their name, looking them up in Enterprise Health, verifying that their consent form was completed. If the patient had not completed their consent form prior to coming in, we do have iPads and laptops, as well as QR codes to the portal systems available, so they could scan that with their personal mobile devices as well and complete those requirements prior to getting vaccinated. We ensure that no changes have occurred since they completed their consent form, and we did combine our consent form and the health assessment questionnaire into one electronic document within Enterprise Health. So we are verifying that that they are eligible to receive the vaccination at the time of check-in. If they have any questions, we have medical personnel available for private consults to make sure that they do indeed qualify to receive the vaccination and all their questions are answered prior to. We then document in Enterprise Health that they are receiving the vaccination, so we complete the administrative process, and then we send them down the hall to actually receive the vaccination. After they're vaccinated, they go to the monitoring station where they're monitored for 15 or 30 minutes, depending on how they answered their health assessment. And then we attempt to schedule everyone for their second dose before they leave the area. At the end of the day, we do have an end-of-day injection report that we run. We've been trying here the last few clinics that we've run, doing this throughout the day, and it has worked out well. And we do this because right now we're manually putting in the Oklahoma State Registry all the injections that are done throughout the day. So we do have that injection report that has the data points that we need, and it's essentially a data transfer from Enterprise Health to the state registry, which is manual today, but should be done via HL7 file in the next few weeks. So here's some of our lessons learned. I kind of mentioned the QR codes for each of the portals. That's just been an easy way for people to complete their consent forms that didn't come in, that didn't complete it prior to coming in. We've had a pretty low rate of that. Most people are completing those before coming in, but that keeps them on their own mobile device rather than sharing devices. We've learned that a 1-to-1 or even a 2-to-1 ratio between check-in person and vaccinator is good, because the check-in process really is the longest process between that and vaccinating. The time from them walking in the door to check in, as long as they've done their work on completing the consent form prior to coming in, all the way to the monitoring station, is about 4 minutes per person. So it's a pretty quick process. We can get about 4 people in every 5 minutes. So we schedule 4 people at one time, and then for every 5 minutes. And that's with 2 to 3 vaccinators and then 3 to 4 check-in people. And then at the end of each hour, we do put a 10-minute buffer in just for catch-up in case we did have an influx of people coming in that hadn't completed their consent form, or give bathroom breaks to our vaccinators or our admin staff, that type of thing. Really, we started out with 15 minutes there. We've discovered pretty early on that we really only needed about 10 minutes. And this flow is very giving. We don't, we have a lot of flexibility and some breathing room with this schedule. So it's worked out really well for us. Jeff, I will turn it over to you. That's really all that I had.
Okay, great. Thank you, Tim and Amanda, as well as Dean and Amy. Great content. We've got about 15 minutes left for Q&A. And again, I would remind you that you can pose questions using either the chat or Q&A feature in WebEx. And I know Emily McComb from our shop is going to monitor those. And I'll go ahead and get things rolling with a couple of questions. You know, it sounds like certainly Phillips 66, but Amy and Dean, from what you guys said too, that most employers are kind of opting for, you know, not making this mandatory, but voluntary, and you know, doing the right kind of education and promotion, you know, to get people to sign up to get the vaccine. In those situations where it is voluntary, you know, how are you seeing that people are handling the people who do decline? So I guess I'll start first with maybe with you know, with Tim and Amanda. You know, what are your plans for that 21% who either didn't respond or said, hey, you know, I don't want the vaccine right now. You know, what are your plans in terms of, you know, are those people, you know, going to work from home? Are they going to have to wear a mask? Like, what are some of the strategies that are being put in place there to, you know, to keep the workplace safe?
Well, we're still requiring masking regardless of whether or not you've been vaccinated, and that's going to continue probably long term until CDC changes their recommendations. And that's a discussion that our executive leadership and crisis management and legal are all having, is ultimately, you know, whenever it is, July, August, September, as more of us get vaccinated, what are the plans for how we're going to ensure the safety and protection of our employees, and especially what is the process for the workflow and accommodation for individuals who elect not to be vaccinated. So that's still pretty much in flux.
Dean or Amy, what are you guys seeing among your employer clients?
This is Dean. So we are seeing employers that are pivoting and trying to engage directly with those employees that are not participating in the vaccination program. In some of the facilities we work in, employers are mandating it. Those tend to be a lot of state facilities, but in private settings where there are employees that are not participating, one of the kind of novel approaches we see with regard to COVID that we haven't seen before with, you know, flu vaccinations and other similar programs is direct employee engagement, reaching out to the employees that are declining, offering them information and trying to understand what the concerns or objections are. By and large, those efforts have been pretty remarkably successful. So we're seeing pretty high vaccine uptake rates at the locations that we're engaged in vaccination right now.
Oh, that's encouraging.
Yeah, this is Amy. I'll jump in here quickly as well. You know, I think that one thing that may happen over time, just as we saw with employee reactions to wearing masks, right? I think we could see attitudes changing regarding vaccination. You know, once people really start seeing the widespread benefit and get more information, and like Dean said, you know, direct efforts to reach out to those individuals who are, you know, currently refusing to become vaccinated. You know, I will say that one thing that I've seen with employers that are mandating vaccinations is that they tend to get a lot more objections based on medical reasons, and actually more commonly religious-based objections, which, you know, then become a lot more difficult to change over time, right? So, you know, if somebody has, you know, expresses a religious objection to receiving the vaccine when it's mandatory, they may be less likely to change their mind versus, employer who is strongly encouraging vaccinations and somebody's just not ready, but yet then may change their mind after additional information, education, that sort of thing.
Okay, great, thank you. Emily, I believe we have a couple of questions from the attendees.
We sure do. Can you hear me okay?
Yes.
Great. So the first one is a quick one that I'll actually answer. Amy asked what software the P66 team is using for their health portal, and that is the employee health portal that is a part of Enterprise Health. The next question is for the P66 team. The question comes from Sandra, and she asks, did you use a third party to do the actual vaccine administration, or did your own medical staff do that on site?
Our own medical staff did that, along with our emergency response team. State of Oklahoma authorized emergency response personnel to be trained and certified as vaccinators. So we have 45 people in our two campuses who are on the emergency response team, and we solicited volunteers, trained them to become vaccinators. So everything is kept in-house and organic. We also, our refineries, we have 13 sites in the U.S. 8 of them are going to be vaccinating on site, and they will be using their organic medical group to do vaccinations on site.
Great, thanks, Tim. Next question, again, I'll answer because it's just really quick. Richard asked if we'll be getting a link to the materials and copy of the slides. And Jeff, I believe the quick answer is yes, that'll all be sent out and then posted on the website as well.
Right, yeah, we'll send it out to all the attendees. It'll take us a couple of days just to edit the slides down, and then we'll actually send out a link to a video recording.
Perfect. And then another question. Let me pull it up here. Sorry, just had it. There we go. Also, can we discuss direct threat a bit more? How does this change and evolve with other hazard mitigations in the workplace? Examples, workstations are spaced 6 feet apart, N95s, etc. That comes from Amy.
Yeah, and so my response to that would be, what the EEOC has most recently said in response to COVID-19 vaccinations and direct threat is to follow CDC and OSHA guidance. So, like Tim said, if the CDC is currently continuing to recommend, certain social distancing, currently continuing to recommend wearing masks, currently recommending, different disinfection protocols. I think you're pretty safe if you are following those and evaluating how somebody could pose a direct threat to another employee or customer, et cetera. So I would rely on that OSHA and CDC guidance for running through that direct threat analysis and thinking about, what measures you need to continue to keep in place to keep your employees safe.
Okay. Anything from Dean or Tim or Amanda on that one?
Yeah, I would echo that. I think the guidance out of just about every federal and state agency with respect to COVID-19 has recognized the severity of the threat posed by the pandemic. And I think it is very unlikely that we're going to see any governmental declarations that undermine that severity. So I think most of the guidance is strongly in favor of the need for and efficacy of vaccination programs. Gotcha.
Well, I know, Tim, you touched a little bit on the fact that obviously Phillips 66 operates in multiple states, and you've got sort of varying rules and regulations in different states. And I know, Dean and Amy, that you guys have clients, in multiple locations as well. So you not only have sort of the original, everything has been coordinated state by state with vaccination, and now I know with the new administration, there's an effort to kind of increase the federal role. And you know, I know in working with our clients, you know, that the, you know, all the different guidance from all these different agencies, you know, state and federal, and in some cases even county and city, you know, the rate of change and even the conflicting guidance can be kind of dizzying. You know, what are you guys seeing in terms of the way that employers are you know, are handling, you know, all of these varying and sometimes conflicting bits of guidance?
Well, it's certainly keeping us on our toes. I mean, you know, between the different states and CDC, as the revisions come along, we're finding that we're having to modify our guidance to our employees, contractors on a fairly frequent basis, along with trying to communicate with the state on how it impacts our ability to vaccinate our employees. For example, CDC last week just moved essential infrastructure employees up into phase 1C, I believe, and the state of Oklahoma still has them in phase 2 or tier 2. So we had to reach out to the state last week to find out, you know, does Oklahoma have plans to move essential workers up into a higher tier? So, you know, the Oklahoma has said no, they're going to continue with the current tier system, but it is something that each one of our sites, we end up as the state or the federal government makes revisions, we're having to constantly keep up on them, and keeps us busy, keeps us employed.
For sure. Okay, Emily, I think.
Even from a technology standpoint, the registries from state to state are so different. So that's one thing I would encourage. If you plan on having any type of an integration, reach out to your state registry folks and figure out what the requirements are going to be, because they are different from state to state. The speed in which you can get an integration set up, or if you can get an integration set up, is also different from state to state. So we have had some of those challenges from a technical standpoint as well.
Yeah, for sure. And I know we've worked with dozens of states, and many were you know, not prepared for something of this magnitude. You know, they're typically working with maybe hospitals and doctors' offices on things like flu vaccines and childhood immunizations, and you know, the scale and speed of this has been a little bit staggering. I think we have time for one more question, and Emily, I believe you have one more that came through the chat.
Yeah, we can sneak one last one in. That would be great. This is probably more on the legal side for Dean and Amy. If our staff, if our medical team gave a vaccine to an employee and there were side effects, and the employee wanted to go to the doctor or, you know, have some medical attention, would that be a workers' comp claim for the employer?
The answer is it could be. You know, it's going to depend on the workers' comp statute in place in that particular state, and whether under that particular state's workers' comp statute, that would be viewed as a workplace illness or injury. You know, from the perspective of the employer, you know, the employer probably isn't going to be making that determination under their state statute. So, you know, if I were advising someone in Indiana, I would say, you know, don't stand in the way of your employee making a claim for workers' comp, and let, you know, your workers' compensation board and insurance figure that out for you. As I said earlier, some states, though, are even modifying their workers' compensation statutes to provide immunity for employers who are administering COVID-19 vaccines. So it could be that in the state in question, you know, there's a change in the workers' compensation statute such that it wouldn't be covered. But it's really going to be dependent on the workers' compensation statute in effect in that state.
I will jump in and say it is fun to have Amy talking as a lawyer, so I can talk a little bit less like one, and say that, well, that's a great question to have from a theoretical perspective. I would encourage employers to not let questions like that adversely influence their decisions regarding occupational health or vaccination. The incredibly small risk of a adverse effect for an employee, the incredibly small corresponding risk of a workers' compensation claim that may or may not have merit is a relatively small effect to counterbalance the incredibly broad positive effects that we're seeing from mass vaccination campaigns and that we see generally from occupational health interventions. So it's good to ask the question, and I think Amy gave a spot-on technical answer, but it's also good to keep in mind the broader context in which we're making decisions like this.
Okay, great. Well, hey, unfortunately, we've run out of time, and as always with these things, it's been a great discussion, a great exchange of ideas. Really want to thank all of our panelists, Amy Adelaide from Krieg DeVault, Dean Frieders with Work Health Solutions, and Tim Raycobb and Amanda Guilfoyle with Phillips 66. I know you guys are all very busy, especially right now as we're in the thick of COVID vaccinations, so we really appreciate your willingness to get everything ready and to present and answer questions. And you guys are doing some really impressive things, and we really appreciate your time. Thanks to everybody who attended today as you work through the legal and logistical challenges that are associated with getting your COVID jabs in. And again, we'll send out a link to access a recording of the webinar along with some follow-up material here in the next couple of days. So again, thanks everyone, and everyone stay safe out there.
Thanks, Jeff. Take care.
Thank you.
Thank you.
Thanks, Jeff and Emily.
Yes, thank you.